Okay, good morning everyone. Today we are going to continue with our book club on the fundamentals of diagnostic radiology. Today we are going to speak about two chapters. This is the pelvic calyceal system, the ureter and the bladder, and the chapter on the genital tract, the CT and MRI and radiographic imaging. It will be presented by your colleagues, Dr. Abbas. May he start.
Thank you very much, dear Dr. Teacher. First, we start with the chapter of pelvic calyceal system, ureter, and bladder. Regarding the imaging and anatomy of the pelvic calyceal system, here we compare two different images. This is a CT urography, and this is a conventional IVP or intravenous urography. If you compare these two images, CT, of course, has more advantage over the conventional one in that it show more detail about the soft tissue, and in the native CT, nearly all stones can be seen, unlike conventional radiography. But the single advantage of conventional IVP or IVU is that the pelvic calyceal system, the spatial resolution is better than the CT urography. For example, here we can see that the detail of the calyces, even the minor calyces or the fornices, even can be seen by conventional one. Regarding the normal variants in the pelvic calyceal system, if you see the normal right kidney and right pelvic calyceal system, there's excretion of contrast, normally enhancement of the kidney with excretion of the contrast into the right pelvis, which is normal size, but in the left one, we see there is a distended large pelvis. This is what we call extra-renal pelvis. The point is to differentiate extra-renal pelvis from hydronephrosis in that there is no associated calyceal dilatation here, and if you follow the other images below the pelvis in the ureter, you see that there is no dilatation of the ureter. So this point is to differentiate between the two, between hydronephrosis and extra-renal pelvis. Regarding congenital anomalies, we will try to discuss one of the most common congenital anomalies of the urinary tract or the pelvic calyceal system, which is duplication. Duplication of the pelvic calyceal system, you have complete and incomplete. Here in this 3D reformatted CT urography, we see there's two pelvis which are they didn't unite. It is a complete duplication of the ureter and the pelvis down to the ureter. This image at the level of the lower pole of the kidney, this points to the lower pelvis, while this one, which is opacified and filled with contrast, it's upper ureter. So this is a complete duplication, and we follow this image in the below the levels below the ureter. We see both two ureters which are twisted or somewhat parallel together down to the pelvis. Most important thing about the duplication system is the Weigert-Meyer rule. The Weigert-Meyer rule states that the ureter draining the upper pole passes through the bladder wall to insert inferior and medial to the normally placed ureter draining the lower pole. Of course, the upper ureter here at the level of the upper ureter more prone to obstruction because there is associated urethral in the upper in the ureter draining the upper moiety, while the lower moiety prone to vascular reflux. So in this image we see dilated pelvis, dilated ureter, with, of course, there is thinning or loss of cortical thickness due to chronic obstruction. As we see, there is no opacifying pelvis and ureter due to a delayed excretion of the contrast, while the lower pole, the same patient below at the level of the lower pole, there is excretion of the contrast into the lower pelvic calcial system, and this points to the upper ureter, which is not opacified due to chronic obstruction and delayed passage of contrast. Regarding renal stones, of course, there's too much talk about renal stones. As we said, most of the renal stones are can be seen by native CT KUB, while for conventional radiography, about 80% of stones could be seen, especially in the ureter. This image, there is a Stockholm calculus. This is non-contrast conventional radiograph KUB. There is a large stone involving all the calces, just like concrete. This is Stockholm calculus. Usually they are struvite stones composed of ammonium, magnesium, and phosphate, and they are usually due to infection, alkalinization of the urine and infection. Appearance of the ureteric stone or urolithiasis first is a high attenuation stone within the ureter, so you can see the stone, especially in the CT. Or proximal dilatation of the distal, proximal dilatation of the ureter and distal contraction of the ureter. This is a sign of obstruction. And the most important one is the tissue rim sign. Tissue rim sign is due to wall edema around the stone. There is a soft tissue attenuation around the stone called the tissue rim sign. And finding of urethral obstruction was a mild dilatation of the pelvic calcial system, 3 millimeter proximal to the stone. Second, slight decrease in the attenuation of the affected kidney caused by edema. Decrease in attenuation in the native CT. While if it is there is contrast, there is increased dense nephrogram. And the third one is perinephric soft tissue stranding representing edema in the perinephric and periureteric fat. This is due to obstruction. Pitfalls in the diagnosis include. So what are pitfalls in the diagnosis of ureteric stone? First, peripelvic cystis or extrarenal pelvis simulating hydronephrosis. But of course, there is no excretion of the contrast, and they are not communicating with the pelvic calcial system. Second, pre-existing stranding in the perinephric fat caused by previous inflammation, especially common in the older patient. Atherosclerotic calcification, chymamic stone. Recent stone passage without stone currently present. And finally, phlebitis. Phlebitis, they are commonly, not commonly, but sometimes become problematic with the differentiation from the stone. Pointers to differentiation from the stone is made by, first, location is not along the course of the ureter. It's either away or inferior or somewhat, it's not along the course of the ureter. Absence of soft tissue rim sign. This is the most important one. In phlebitis, you cannot see it. Presence of the tail sign. A tail sign is a tubular tail extending from the calcification representing thrombocyte vein. And finally, a relatively low attenuation of the phlebitis with mean value of 160. Most stones are above 200 and even 1,000. These images are from the ureteric stone. Here, this points to the dilatation of the pelvis with the periureteric stranding, soft tissue stranding, which represent edema and due to chronic obstruction. And this is what we call the soft tissue rim sign. Soft tissue rim sign. here we see a stone, and this surrounding edema is wall of the ureter called soft tissue remsine. Here points to the stone again in the left uretrovesical junction. Also there is soft tissue remsine. But sometimes there is a stone, but you cannot see the soft tissue remsine. Why? Because due to blooming artifact of the stone, as the stone is too much dense, you cannot see here soft tissue remsine. This one points to the perinephric edema. Perinephric edema, of course, as we said, due to obstruction and dilatation of the pelvis. But here, this points to the phlebolea. As we said, there is no soft tissue remsine. It is location is at the level of the prostatic veins. So it's position, and of course, it must be less dense than the, especially if you measure by house film, less denser than the stone.
The picture of the perinephric edema, it's representing calyceal rupture due to obstruction by the stone. Fluid leaking, urine leaking from the kidney, rather than just edema.
Yes.
Urine leaking.
Edema was transient.
Yes. You should keep that in mind.
Some point about bruchid stones. What are bruchid stones? They present about 2 to 4% of stones. They are a unique form of calcium phosphate stones. Tends to recur quickly if patients are not treated aggressively. And most important thing is they are resistant to treatment with shockwave lithotripsy. Regarding hydronephrosis, as we see, if there is obstruction or if there is some previous insult, there is hydronephrosis, mean dilatation of the pelvis and calyceal system. Here this points to the calyces, which are dilated with a thin soft tissue, remaining soft tissue cortical signal. Here again, due to the obstruction, there is enhancement of the cortex, but there is delay of the excretion of the contrast if you compare to the left side, and there is edema, and the medulla is not enhancing still. Well, this is due to persistent dense nephrogram due to obstruction. If you use MRI the MRI urography, this is the native. These are the native MRI, and this one is after injection of the gadolinium. This is a T2 showing dilated calyxes and the pelvis, dilated and ureter. And if you see a cross section at the level of the stone, you can see the stone as a phlevoid here. This points to the phlevoid stone surrounded. Filling defect.
Rather than phlevoid, because it's not a vessel.
As it is calcification, maybe yes. Then surrounded by urine, because urine passes between the stone and the wall of the ureter, which is hypointense, appears hypointense. This is represented as the wall of the ureter. This is after injection of the gadolinium. This also points to the filling defect in the representing the stone and dilatation of the pelvis and calyces. While the normal right one, there is no dilatation. We have mass or filling defects in the pelvic calyceal system. We have too many differential diagnoses, but we will try only cover the one which have picture. If you see this, there is hyperattenuation or dense calyces. These are representing hemorrhage or hemorrhage into the pelvic calyceal system, which are a cause of mass or filling defect in the pelvis. This points to the transitional cell carcinoma, which is a soft tissue tumor, also appears as a filling defect. And this one points to the increased pelvis wall thickness because it is diffuse transitional cell carcinoma. Again, this is represent soft tissue mass, usually arising, this one arising from the lower pole calyces, causing obstruction of the upper calyces with dilatation. Again, this is also a non-contrast study showing a soft tissue in the density in the pelvis, again representing tumor or transitional cell carcinoma. Again, tumor in the ureter or transitional cell. There is the filling defect, points to the filling defect outlined by the contrast excreted urography. And if you compare these two images, there is excretion of the contrast in the left ureter with opacification, but the right ureter is not opacified due to an obstruction by a soft tissue mass, which is pointed. If you see, this is another type of contrast, which is retrograde pylography, in which there is a filling defect here. This is the ureter because the contrast passes here upward, outlining the soft tissue mass, and after further contrast, the contrast, there is a delineating the soft tissue mass surrounded by this contrast.
This is what they call the champagne glass.
Something
It looks like a glass of champagne, the one on the left side.
yes, this one.
Like the other one, sorry, the right side.
No.
You know, it's like a glass.
Yes, this is representing a mass, and this is a. Yes. Yes. Another differential diagnosis for filling defect or mass in the pelvic system is papillary necrosis. Here there is a filling defect, which is not a tumor and not stone. This is just sloughed papilla, which is lodged in the calyces. And if you do an IVU or conventional pyelography, there is opacification of the site of the sloughed papilla, which are these points to the side of the sloughed papilla. Another anomaly of pelvic system is duplication. Diverticulum. The diverticulum is can be separated from the cyst, but that there is communication with the calyces, but there is a single dilatation. So this is not a hydronephrosis. Again, this on a conventional one, we see diverticulum, which is connected to the pelvic system by the very tiny duct. Going to the bladder, one of the congenital anomalies of the bladder is the urethral remnant. Urethral remnant, which is attached from the dome of the diaphragm to the umbilicus. If there is there are many congenital anomalies regarding urachus, such as sinus, cyst, tract, or fistula. All can be. What this points to a complication of the urachal remnant, which is the soft tissue mass contains calcification, which is proved to be carcinoma, urachal carcinoma, which are most of them adenocarcinoma. It's not a transitional and not squamous carcinoma. Thickening of the bladder wall and small bladder capacities. For example, in this patient with BPS or benign prostatic hypertrophy, due to enlargement of the prostate, there is elevation of the bladder. The shape of the bladder is elevated, and there is increasing wall thickness due to chronic outlet obstruction, and the ureters are opacified, and they form a J-shaped or hooked shaped because elevation of the both the bladder and the ureter. Another cause of thickening bladder wall is cystitis. Cystitis, which is also causing increased wall thickness associated with surrounding edema and stranding. Emphysematous cystitis is a form of cystitis in which there is gas formation in the wall of the urinary bladder, mostly caused by Escherichia coli. This conventional one, there is a radiolucent halo in the urinary bladder wall, and after CT there is also localization of the gas in the wall of the urinary bladder, representing emphysematous cystitis. Calcification of the bladder wall is, of course, there are many causes of calcification in the urinary bladder, such as schistosomiasis, TB, CA, and all. Stone, even chronic cystitis can cause urinary bladder wall thickness. The point to differentiate schistosomiasis, which is a common cause in the Egypt and South Africa and even south of Iraq, called bilharziosis. It is common. The point for differentiate schistosomiasis from TB is that in schistosomiasis there is the capacity of the urinary bladder affected later, while in the TB there is yearly decreased capacity and rigidity of the urinary bladder. Bladder wall mass or filling defect. Of course, you have two types of hydrocele. Urethral, this is the simple one, which is present in the normally positioned ureter, while the ectopic one, as the name, it is located at the ectopic ureter, and this points to the normally positioned lower ureter. Transitional cell carcinoma of the bladder, it's of course appears as a polypoid or papillary-like projection or diffuse wall thickening. This points to the this soft tissue elevation or mass in the urinary bladder. This is a CT, native CT, surrounded by this low attenuation urine. After contrast, this is the urinary bladder filled with contrast, but the soft tissue become more apparent as a papillary projection.
The first one is not a native, it's a contrast CT. And the second one is a delayed phase CT. This is contrast. The
This
first
one?
Yeah.
This is a contrast.
Or both of them with contrast. The first one is also with contrast. You can see the contrast in the vessels and the enhancement of the mass of the lesion. Yeah, not delayed. The second one is delayed. Okay, don't worry. Continue.
This is after contrast, there is enhancement of the soft tissue. Again, this is points to the transitional cell carcinoma involving the right uretero-vesical junction, and dilatation of the ureter is a point to invasion of the bladder muscle and the junction. Bladder stones may be passed from the kidney or formed in the bladder, but importantly, they must be removed because there is recurrent infection and predisposing to the development of the carcinoma. Bladder diverticulum is also common, especially in the old male patients of BPAs or chronic outlet obstruction. You can see bladder diverticulum, which are outpouching connected to the urinary bladder. Bladder rupture, we have extraperitoneal and intraperitoneal rupture. Extraperitoneal usually occur when the bladder is empty at the time of the accident. We see extravasation of the contrast into the radius region or retropubic region, or sometimes we see contrast extravasation into the thigh. While the intraperitoneal, which usually occur in the case of urinary bladder filled with urine and time of injury, and the contrast extravasated to outline the walls of the bowel up in the peritoneum.
Is it important to differentiate intra from extraperitoneal rupture, and why?
Yes. Of course, it's
why?
Management.
What's the management? Extraperitoneal, they just put a Foley catheter and wait. It will heal by itself most of the time. While intraperitoneal needs to be open surgical repair because it might simulate acute renal failure. There is no urine and the urine that's excreted from the urinary bladder into the peritoneal cavity gets reabsorbed, resulting in increased urea and creatinine.
Yes.
So you need to fix it surgically.
Coming to the urethra, of course, we consider it on male urethra. This is we have two types of imaging. The first one is retrograde urethroplasty, and this one cystourethroplasty or the antegrade urethroplasty. In retrograde, we insert a catheter or a syringe, and usually the balloon may be inflated in the navicular fossa, and we inject contrast. Then we take an image from the right posterior oblique position. Regarding the anatomy of the male urethra, we have anterior and posterior urethra, which are separated from the urogenital by the urogenital diaphragm. The anterior urethra, starting from the tip of the penis, called penile urethra, which is at the time of when the junction of the penoscrotal junction, there is a ligament called the suspensory ligament of the penis. It separates the penile urethra from the bulbous urethra, marked by this elevation. Then the bulbar urethra start with and end at this cone-shaped configuration in the retrograde one. This cone-shaped configuration is representing the starting of the urogenital diaphragm or the external sphincter. Then the posterior urethra start, which are membranous and prostatic urethra. The membranous one start from this cone-shaped narrowing to this impression in the posterior wall. It's called verumontanum. So this region, which is about 1 cm, is a least distensible part of the urethra and prone to injury at time of accident. Till from the distal end of the verumontanum to the neck of the bladder or the bladder is prostatic urethra, which is about 4 cm in length. Point is to differentiate between these two, retrograde and voiding cystourethroplasty, is that the posterior urethra in the voiding one is better visualized because due to the presence of I think valves, not.
It will fill in the voiding, while in the retrograde one it will not fill properly because the contrast, when it passes the membranous urethra, it will pass freely into the bladder.
Yes.
It may make that.
Yes. Again, prostatic urethra down to the verumontanum, then membranous to the urogenital diaphragm, then bulbar urethra to the penoscrotal junction or the attachment of the ligament of suspensory of the penis, then then penile urethra. We have two types of glands. First, Cowper's gland, which are present in the membranous urethra. The glands are themselves in the membranous urethra, but their ducts are open about 2 cm distal to the bulbous urethra. While glands of Litri we have, they are present throughout the interior urethra, both in the penile and in the bulbar urethra. Normally, we may be seen the Cowper's ligament may be filled with contrast, as in this case, without any disease. But presence of these small, short duct glands, which are glands of Litri, they are almost always pathologies due to stricture or infection, such as gonorrhea or any other causes. This is a urethrogram showing multiple strictures here and opacification of these glands. MRI of the female urethra here points to the rectum, vagina, at anterior vaginal wall, anterior to the vaginal wall, there is female urethra represent as a target sign. We have this central hypointensity, which represents mucosa, while the submucosa, which is intermediate or high signal, then surrounded by the muscular wall, which is also appears as a hypointense. This pointed to the carcinoma of the penile urethra, which are most of them squamous cell carcinoma, appear as a soft tissue mass, causing displacement of the corpus spongiosum, corpus cavernosum, and the urethra, of course. And this is traumatic urethral transection in which there is extravasation of the contrast to the surrounding tissue, and also intravasation of the contrast into the pelvic veins, which are opacified, and there is no opacification of the urinary bladder, representing traumatic transection of the urethra. Classification of the posterior urethral injury have 5 types. Type 1, there is contusion without imaging finding. Type 2, there is stress injury with elongation of the urethra without extravasation. Type 3 is a partial disruption with extravasation of the contrast agent from the urethra with opacification of the bladder. While type 4 is a complete disruption of the urethra without opacification of the bladder and with urethral separation from the bladder less than 2 cm. Well, type 1, there is more than 2 cm. Again, there is no type 5. Diverticulum of the female urethra is a conventional contrast radiography showing opacification and filling of the diverticulum of the female urethra with contrast. They are usually located at the posterior wall of the female urethra, and of course they are appears in MRI, especially in T2, as a hyperintense signal because contain urine. Going to the next chapter, which is genital tract, CT and MRI. First, female genital tract, and we will try to consider an anatomy, congenital anomaly, benign condition, and last one is in gynecological malignancy. Regarding the anatomy, you see this is best sequence for uterine anatomy is T2, in which there is a hyperintense mucosa surrounded by low signal or hypointensity transitional junctional zone. Then the myometrium, which is intermediate signal intensity. These are points to the presence of Nabothean cysts, which are commonly seen in the cervix. They are due to dilated cervical glands. Then the vagina, which is because it's muscular, usually it is a hypointense. Anterior is the bladder, and posterior is the rectum, of course. The ovary is also best seen by T2, as the follicles are filled with clear fluid. They are appear as hyperintensity. So the best sequence for ovaries is again T2. In CT, we can see the ureter contain this low attenuation fluid, urinary bladder, ovaries, and broad ligaments. Again, ovaries with the broad ligaments. Some points about the congenital anomalies of the uterus. We have septate uterus, in which there is a septum dividing the both corners into and a common cause of recurrent miscarriage and infertility. Point is to differentiate bicornuate from septate uterus. Of course, this is not in our book, but Yes. In the bicornuate, the fundus is dimple. So this is a bicornuate. There is dimpling of the fundus, while in the septate uterus there is no this dimpling. Less than 5 millimeter uterine wall above the line joining the tips of two uterine cavities. So if you draw this line, there is less than 5 millimeter soft tissue above this, while in the septate one, there is more than 5 millimeter from the line joining both corners. An angle between the two cavities is more than 90 in bicornuate, while it is less than 90 in septate uterus. And the medial margins of the endocervical cavities, they are convex in bicornuate. These are the endocavities, while the medial margin of the endocavities are straight in the septate uterus. This one straight line. These are points to differentiate between bicornuate and septate uterus. Again, as we said, this bicornuate uterus, if we measure this angle, it is more than 90, and the septate uterus, it is less than 90. There is a dimpling, and there is no dimpling. There is, if you see, draw a line between these, there is less than 5 millimeter tissue above this line. But if you draw the line from between these two corners, there is more than 5 millimeter tissue on this. Leiomyomas, which are called fibroid, they are common finding it in the female uterus. This points to the two small anterior wall subserosal fibroids. Again, this is a fibroid which is appear as heterogeneous due to ubiquitic red degeneration, calcification, and that's why it appears as a heterogeneous signal. While in the CT it appears as heterogeneous, and CT is not a good modality for the assessment of the uterus. In the conventional radiography for the uterus, there is a characteristic popcorn calcification of the uterine fibroid. It can be by other non-radiologists can be regarded as a stone or any other thing, but this is they are typically popcorn calcification. It can be seen. If there is lipid with fat with the leiomyoma, it's called lipoleiomyoma, which on CT or on MRI there is visible fat within the mass. This points to the types of the fibroid, upper cellular cystic dysfunction, red disease, all they appear as a different image. Of course, we have no such time to. Regarding adenomyosis, which is presence of the endometrial glands inside the myometrium, the hallmark of this adenomyosis is in T2 weighted images there is a marked thickening of the junctional zone above 12 millimeter. This is the hallmark of adenomyosis. Regarding ovarian cysts, we have simple ovarian cysts, and simple ovarian cysts can be complicated by hemorrhage or infection or even torsion. The simple one may appear as a thin wall cyst, contain low level, contains low attenuation fluid on CT. Sometimes there's enhancement of the wall, or sometimes there is fluid level due to, as we said, hemorrhage in the cyst. Endometrioma is the presence of endometrial glands outside the uterus, endometriosis. While endometrioma, there is a loculation of the endometriosis due to recurrent hemorrhage forming a cyst, which is usually appear as hyperintense in T1 and hypointense called shading sign in T2. T2 shading, yes. Hydrosalpingus, her hysterosalpingogram showing dilatation of the distal part of the left fallopian tube, of course due to chronic obstruction or infection. And if you do an MRI, there is also dilatation, fluid-filled structure, which is mostly convoluted in the appear in MRI. Of course, due to presence of fluid inside the uterine tube, causing dilatation. Tubo-ovarian abscess is also a complication of the infection. We have any other entities, benign cystic teratoma, peritoneal contusion.
About the benign cystic teratoma, it's a common in that we need to review it. Well, in benign cystic teratoma, as we know, presence of fat is diagnostic on CT or MRI or whatever, has a very characteristic feature on ultrasound. It has calcification that usually in the shape of a tooth. That's a diagnostic of benign cystic teratoma. Okay, what else?
Peritoneal inclusion cyst. Point is, most important one is to differentiate it from the ovarian cyst.
Ovarian cyst.
Because it's not functional
cyst
cyst.
due to entrapment of the ovary by adhesions.
Yes.
The ovarian secretion will cause pressure symptoms and possibly infertility, pain, and things like that. However, unfortunately it's difficult to treat, and it will recur unless oophorectomy is done. The definitive treatment is by oophorectomy. It recurs always. What else?
Ovarian fibroma.
Ovarian fibroma, there are multiple fibrous tumors of the ovaries. Fibroma, fibrothecoma, thecoma. They are usually associated with ascites,
Yes.
okay, and Meigs syndrome, things like that. But they are benign tumor, not malignant.
Yes.
Okay.
Gynecological malignancies. At first, we have ovarian malignancies. This image of cystic adenocarcinoma of the ovary. Usually, there is a solid soft tissue mass, sometimes associated with cystic changes. MR and CT signs of ovarian malignancy. Wall thickness greater than 3 millimeter, nodularity, visitation, and solid component, evidence of invasion of the adjacent structures. Ascites, contrast enhancement of the peritoneum, also a sign of malignancy. Adenopathy, also visible in malignancy, representing metastasis. This is peritoneal metastasis from the ovarian carcinoma. In this conventional radiograph, there is calcification, but where is the calcification? We don't know about by conventional. And if you do CT, there is thickening and nodularity of the momentum, representing peritoneal metastasis from the ovarian carcinoma. Metastasis to the ovary usually from the gastric carcinoma. They are bilateral, called Krukenberg disease. Yes. Cervical carcinoma. This CT showing a large soft tissue attenuated mass with ill-defined surrounding fat stranding, indicating invasion of the adjacent structure. While in MRI, there is only you can see the very thin surrounding remaining rim of the normal cervical, which is appear hyper as cervix.
So there is no extension beyond the cervix. There is
Yes.
some free fluid, but there is no extension.
Yes, it is replaced by this intermediate signal intensity, which is representing soft tissue, tumor or carcinoma. Figo staging, you can have a time for figo staging. Endometrial carcinoma is another entity.
The most important thing in endometrial carcinoma usually presents in postmenopausal bleeding is to determine the extent of myometrial invasion. Is it more than 50% or less than 50% of the myometrium? This will affect the staging and management of the patient. Okay?
Yes.
So is the junctional zone invaded? If it is invaded, how much? Less or more than 50%? Okay? Next. Again, there are multiple staging systems. Leiomyosarcoma is rare but very aggressive
Yes.
form of malignancy affecting the uterus.
And most
Okay.
important one is to differentiate from
Yeah,
benign
differentiated from what?
from benign fibroadenoma,
Okay.
fibroma.
Okay.
Carcinoma of the fallopian tube, with another carcinoma of the
The
vagina.
nice thing about fallopian tube carcinoma is that usually it is small. at presentation. So it can be detected a little bit earlier than other kinds of carcinoma.
Yes. Carcinoma of the vagina represented as increased in its wall thickness with sometimes
More commonly, carcinoma of the vagina. Vagina is affected by extension from adjacent tumors, like bladder or rectum, rather than primary malignancy of the vagina.
Yes. Male genital tract. This point is to just deline it because there's too many doctors already. These are testicles, which are appear as a hyperintense or intermediate signal intensity on T2. This is represents spermatic cord, suspended by spermatic cord, and this is the cross section of the penis. These are corpora cavernosa, and this is corpus spongiosum containing urethra, and this is pointed to the epididymis. Again, undescended testes usually the best imaging modality for undescended testes which are not in the superficial or the inguinal. That it is intraperitoneal. The basic imaging modality is CT, of course, which because it may be atrophied in MRI, could not be seen well. Regarding prostate, zonal anatomy of the prostate, it is a central zone, this transitional zone, central zone, this peripheral zone.
Central zone is the source of benign prostatic hypertrophy, while peripheral zone is usually the source of prostatic carcinoma.
Yes.
Okay?
Yes.
However, most prostatic carcinomas can affect the life of the patient or not. So this is the question. Most of the people that have prostatic carcinoma, if you do nothing, they will die from MI, for example. Severe. Just leave him. Okay? Others, the prostatic carcinoma will be the cause of death. So this is the question. This will affect the patient's life expectancy or not, lifespan or not? This is the important thing. And prostatic carcinoma cannot be diagnosed by any imaging modality, including PET. حتى بالPET, difficult to be diagnosed. So this is the problem.
This appearance of the prostate, I don't know if there's time for it or not. Prostate carcinoma appear in T2 as a hypointense mass in the hyperintense peripheral zone. Criteria for extracapsular extension of the tumor, asymmetry of the neurovascular tumor, involvement of the neurovascular bundle, irregular contour of the prostate gland, irregular spiculation, margin of the prostate gland, and obliteration of the rectoprostatic. And this is BPH, which appear as a heterogeneous signal intensity in the MR.
This is an incidental finding. The usually called cyst or Mullerian duct cyst can cause some symptoms of obstruction, but most of the times it is incidental finding. And regarding benign prostatic hypertrophy, keep in mind it's not the size of the prostate that is important, it's how much obstruction it causes. If the patient wakes up more than twice at night, this is a significant obstruction. If not, even if the prostate is large, it's not significant. It's not obstructing the lesion of the urethra. Sorry.
Normal seminal vesicles in T2 they are hyperintense. This is calcification of the vas deferens, which usually occur in the diabetic patients. And thank you. And I don't know it's time for example.
Okay, I think it was an excellent way to present the